Hello, everyone. We are talking about neurology this week. So here's our objectives. So first of all, we're going to talk about the cells. The cells in the nervous system are the neurons. They are very, very unique, specialized cells. If you don't remember the parts of the the neuron, here's a kind of a reminder for you. So the nucleus, the endoplasmic reticulum, the mitochondria, all of that is in this part of the neuron. The dendrites are these kind of projections out, kind of appendages out, and those are what will go towards another neuron. You have the axon here, which is this kind of projection out from the cell body, and then you have the teleodendria, which are what kind of not more of those dendrites coming out to the synapse. And the synapse, as you know, is a space between the neurons. So they don't divide like other cells. And if you injure the central nervous system, so the brain or spinal cord, that is permanent. Now, peripheral cells do repair through an axal reaction. So peripheral neurons will repair. So if you have a injury to an extremity or something like that, and you might have affected the nerves, and maybe you don't have a lot of feeling or something, or chronic pain in there, those two tend to repair, whereas the brain and the spinal cord do not. So the Schwann cells are the myelin-forming cells, and they are along the off of the body of the neuron. I keep wanting to say nephron, neuron. We're talking about the nervous system. Sorry about that. So the Schwann cells here are along here, and they make the myelin that covers the cell. And that is important because that is an insulating body so that the electrical activity going from the cell body out to the far dendrites stays in the cell and doesn't scatter. So it's important for those Schwann cells to be there to make the myelin sheath. And it produces layers of laminate and the more layers, the more insulation, so the faster the conductivity. This is where autoimmune diseases that affect the nerve cells attach and cause damage. So we'll talk about Guillain-Barré in a few minutes, but this is where the problem is. If you have damage to the myelin sheath or the myelin, then you have scattering of electrical activity, and the nerves are not functioning correctly, and they will scatter to other neurons that it should not be going to, or it's a very slow process. Non-myelin forming cells are part of the autonomic nervous system. You have the perisynaptic cells and the perineuron cells, and those, of course, will be along the body on the whole cell of the neuron. And then, of course, Schwann cells are required for the maintenance of the nervous system function. So a nerve impulse is crossing a synapse. It's crossing a space. So the cells are not touching. There's a space between them. And this is where the neurotransmitters are released into the synapse. And then the other neuron has channels where those neurotransmitters are pulled in, and that is where the impulse goes across. And depending on which neurotransmitters are released, depends on what the nerve is going to do. Now, you can have convergence of neurons, and this is where many neurons are firing on one neuron. So it's getting lots of impulses into one. Or divergence is where one is firing out and it's going to multiple neurons. So neurotransmitters or neuromodulators, there's a lot of them. There's a lot of them, and it depends on what they are as to what they do. So if you are saying, do I need to know all these? Unfortunately, you do. The reason you need to know these is because of the disease process that may affect these. And also, you need to know as far as medications. Medications will be very selective on which one they are affecting. So, acetylcholine, that is an excitatory or inhibitory neurotransmitters. There's the monoamines, so you have norepinephrine, it's excitatory or inhibitory, and this regulates your sleep-wake cycling and your mood. Serotonin, which you've probably heard of, serotonin release inhibitors, those kind of things, or um, reuptake inhibitors. Those are, if you have a medication that's a serotonin reuptake inhibitor, is what it's inhibiting is that normally the neuron pulls back the neurotransmitters, and with SSRIs, they inhibit that reabsorption of them. So there's more serotonin in the synapse. So it is generally inhibitory, but it is important for mood, anxiety, and sleep. Dopamine is generally exhibitory, histamines, exhibitory, and inhibitory. So again, we have those histamines that play a large part in our body. Amino acids, we have GABA or gamma aminobutyric acid, and this is a postsynaptic inhibition of brain. Glycine, this is a postsynaptic inhibition of the spinal cord, and glutamine and aspartate are excitatory. Neuropeptides, endorphins, and ecephalins generally inhibit. They are where the opiates bind to these receptors to reduce pain. That's what we think about that with endorphins. It makes you feel much better. Substance P, this is generally exhibitory, and this involves pain transmission. So you'll see this neurotransmitter if pain is going along the neurons. Also, vasoactive intestinal peptide, and this is generally excitatory, and this stimulates secretion, vasodilation, and smooth muscle relaxation. So, for the sympathetic preganglionic and the parasympathetic preganglionic and the postganglionic release, acetylcholine, which is a cholinergic. So this causes you to be more attentive, more alert, and more aware. So we have the nicotinic, which affects the CNS and the neuromuscular junction. We have the muscarinic, which it affects the central nervous system and the peripheral nervous system. And these increase secretions. It decreases your heart rate. It causes you to sweat, and it relaxes the sphincters. That doesn't sound good, does it? Let me move on. Postganglionic sympathetic release norepinephrine, which is adrenaline. And so this is an adrenergic. So you have cholinergic and you have adrenergic. Adrenergic is kind of where you are more alert again. You have dilated pupils. It increases your heart rate. It mobilizes energy, more alert, puts you on more of a stress response, more of a um, feeling of anxiety or feeling of, well, I don't want to say impending doom, but more of alertness or what's going to happen to you. Catecholamines, those are epinephrine, norepinephrine, and dopamine, and these are released by the adrenal medulla. And then we have the adrenergic receptor alpha. So alpha 1 is the excitation or stimulation, and alpha 2 relaxes and inhibits. And then another adrenergic receptor is the beta. So beta 1 increases the heart rate and contractility, releases renin from the kidney. Beta 2 facilitates the remaining effects of the beta receptors. Norepinephrine, this is released by the thalamus. You have an alpha, beta 1, and certain beta 2 adrenergic receptors, so this causes vasoconstriction. Epinephrine has all four receptors and it causes vasodilation. And then dopamine, this is a precursor to norepinephrine and epinephrine. There are five different dopamine receptors and they vary in function. So dopamine is a very important neurotransmitter. It changes our pain, or I'm not pain, pleasure. So dopamine will affect if you are having depression or if you are more on the happier side. It affects our motivation, cognition, let us think clearer, attention, memory, learning, fine motor control, sleep regulation, hormonal regulation, sympathetic regulation, penile erection, and immune function. So it has a lot of functions. So when we talk about some of the diseases that affect dopamine, you can see how it really can affect the whole body in many different ways. So here on the brain, there are some different areas. Um, and I just kind of shared this with you. You, you know, I'm not expecting you to say where things are located. I won't ask you like, where's Wernicke's area or anything like that. You will have to know some of this for 605 when you do assessments, so I don't really go into that as much. But just remember, if you have damage to a particular area, you can see how that would affect certain neural functions. So vision is sitting way back here, and you think that doesn't make any sense because your eyeballs are up here, but vision actually sits at the back of your head. So if you have a injury or tumor or something back here that can affect your cortical vision. So your eyes are fine, the optic nerve is fine, but the perceived part of the brain is damaged, so you don't perceive it. So they call that cortical blindness. For the somatic and sensory areas of the cortex of the brain, it kind of goes over that as well. Again, I'm not going to ask you this, but it just, if you look at this, it's kind of a cool picture that the different areas here along the brain, you can see how they affect each side. The cranial nerves, you do need to know though. So olfactory is one, optic is two. So I'm not going to read through all of them, but just to know, like ocular motor is your pupils. It regulates your pupils dilating and constricting. Trochlear, this is where, again, your eyes, you can follow moving objects, so your eyes are moving together. Trigeminal, this is the sensory of your face. The trigeminal runs along the face. Um, Abductans, move your eyes laterally from side to side. So you see a lot of these nerves here are all having to do with the face. Facial is seven. That's facial expression and taste. Vestibular cochlear is your hearing. Uh, Glossopharyngeal is the pharynx and salivary glands. Vagus is not in Nevada. It is your sensory and motor impulse for the pharynx. And this runs by parasympathetic nerves, or the majority of those. And when we talked about parasympathetic, remember it talked about decreased heart rate. So remember, if you stimulate the vagus nerve, your heart rate will drop. Spinal accessory, and then hypoglossal, which is motor movement or tongue movement. Um, so you see where they're coming off here. I'm not, again, I won't give you a picture and say which one is which. I would not do that, but you do need to know what the number is. So if I say, what is cranial nerve number 5, you can, what does it do? You can say, well, that's the trigeminal, and then it controls the motor and sensory of the face. Dermatomes. So dermatomes are very interesting. The thing about dermatomes is this is where the nerve is coming off of your spinal tract, and then you can see what part of the body that nerve is affecting. This is really, really helpful if you're dealing with people with chronic pain, like back pain or sciatic pain or something like that. You can see here where the nerves are coming off, and it kind of tells you here which are the different nerves. So you see this is the trigeminal. It is affecting the face. And you can see the track then where if there's something wrong with that nerve, if there's pain, you can see the track of where that pain might be. So let's say that I have a pinched nerve in my back and I notice pain that radiates down my thigh and it kind of comes on the inside of the thigh right beside the kneecap. Well, we would know that that nerve then is located between L2 and L3. So those nerves here, if they're inflamed or they're being pinched or something, that is where you're going to feel the pain. So someone might say, oh, I have a lot of pain in my leg but I haven't injured it. It's not swollen. There's nothing going on. Then you can kind of look here and see, well, maybe it's not related to an injury or something in that part of the leg. It may be the dermatome of that particular nerve coming off of the spinal cord. So, we have the autonomic nervous system. This regulates involuntary function of internal organs. So this just autonomic clear as a bell, right? It just does it by itself. You don't need to think about it for it to happen. Like if you think about your respirations, I just thought about it and I'm like, oh, take a deep breath. If you think about your respirations, you just do them, right? If we had to count on ourselves to remind ourselves to take a breath every few seconds, then that's all that would consume us forever. And we all would die young because at some point we would forget or we'd fall asleep or something like that. So the autonomic nervous system is over those involuntary nerves. This is located in the central nervous system and is the efferent division of the peripheral nervous system. So there's efferent and afferent. So efferent is the autonomic nervous system. There is two components to this. There's the preganglionic, which are myelinated neurons, and the postganglionic, which is unmyelinated neurons. So in the CNS area, there's intermediate lateral horns of the spinal cord, and it's also where your cardiovascular and respiratory centers are. So you don't tell your heart to beat, it beats on its own. You don't tell your lungs to breathe, they do it on their own. And this is in a reticular formation, and it also includes the hypothalamus. There are two components to the autonomic nervous system. There's a sympathetic and then the parasympathetic. So the sympathetic nervous system mobilizes your energy. It has that fight or flight response. So this is in the thoracolumbar diversion and innervates between T1 and L2. So there's quite a bit of nerves along there. So you have obviously T12 and then L1, L2. Preganglionic axons on the sympathetic division after leaving the spinal cord, then go to the sympathetic paravertebral ganglia and then along their pathways depending on where you want that to go. And they directly synapse with the postganglionic neurons. They travel up and down the sympathetic chain before forming synapses with the postganglionic neurons. This is divergence. We talked about that. And they pass through the sympathetic chain ganglionic, postganglionic neurons, and then any collateral ganglia. The parasympathetic nervous system is opposite. It conserves and restores your energy. And this is in the craniosacral division and is cranial nerve nuclei and sacral region of the spinal cord. So you have the preganglionic fibers travel to the ganglia, and those go to the organs. They innervate those before forming synapses. that are relatively short postganglionic neurons. The parasympathetic nerves from the nuclei in the brainstem travel to the head, thorax, and abdomen within the cranial nerves, preganglionic peripheral system that originates from the sacrum, and they run separately and together with spinal nerves. So let's look at some of the abnormal things. I don't know if you'd say abnormal, but some of the things that the neuron system will do related to disease. So for pain, pain is actually protective from disease and injury. So pain tells you, if you stick your hand on a hot burner or something very, very warm, you immediately pull it back. This is actually a reflex that goes from the spinal cord back out to the motor neuron, and we perceive what we felt was hot, but we move before we even perceive it. It's just a reflex that we do. It's the same with pain. We withdraw from pain, and again, is a protective thing. So the pathway for pain is in the peripheral nervous system in the efferent pathways. Like I said, you touch something, it goes along the efferent pathways and it travels to the spinal gate in the dorsal horn, then ascends to the higher centers in the central nervous system. These centers interpret in brainstem, midbrain, and the diencephalon, which is your thalamus, your hypothalamus, your epithalamus, and your subthalamus. And then it descends through the efferent pathway from the CNS to dorsal horn of the spinal cord. So it's very quick, and so that you're not like putting there and you're like, oh, this might be hot. By that time you've already caused damage. So it's a very quick response. Perception of harmful stimuli. This is your what we call nociception. And so that's what your brain is interpreting it. Brain doesn't always get that right, though. Um, your brain can only perceive whatever neurons are stimulating. So, for instance, I was in a car accident when I was young, long, long time ago. I hit my head on the steering wheel, and because it hit right around my eyes, I saw a bright light. And the reason I saw the bright light was because around my eyes, yes, you can feel, around there, you can have pain or whatever, but if you hit close to the optic nerve only sends an impulse for light. So if the optic nerve is triggered by that pressure, then your brain perceives it as lights because it's like, oh, it's coming from the optic nerve. It must be a light. There's no light there, but you're going to see a light. So that's why perception can be wrong, basically. So when you stimulate um, these that perception of the harmful stimuli, we call that nociceptive pain. So this is a pain pathway here again. We kind of look at this where, you have the trigger coming in, pain, temperature, sensation from the right side of the body comes in. It goes to the spinal cord. It's going to make you pull away, and then it goes to the central nervous system as what you are perceiving it to be. All right, so mediators that activate nociceptors. So these activate pain, okay? So excitatory um, or inflammatory. So these are what you would have if you are experiencing pain. These are the nociceptors for that. So some of these that we look at for inflammatory, we've already talked about leukotrienes, bradykinin, prostaglandins, serotonin, substance P, we talked about interleukins, some tumor, nitric oxide, ATP, calcitonin. Excuse me. Excitatory transmitters or neurotransmitters are listed here. These probably are not as familiar to you. And inhibitory mediators that decrease pain would be here. So opioids, endorphins, inocephalins. Um, so I don't think that you need to know these as much, but I would want you to know what causes the inflammatory process or pain and what inhibits it. What inhibits it? So fever is also a neurological phenomenon. So what happens is you have some kind of pyrogen. So pyrogen means that it causes a fever. So it could be an infectious agent like bacteria or viruses. It could be a toxin. It could be a tumor, something like that. It could be pressure in the CNS. Usually people with severe head injuries or increased CNS pressure, they usually have temp instability, and that's a neuron thing. So just remember, fever is related to perception of a pyrogen or some kind of endogenous thing coming in. So what happens is when those are triggered, when those are sensed that they're here, the monocytes, macrophages, endothelial cells, and other immune cells are released. Those immune cells release prostaglandins. So that's what this is. PGE2 is just an abbreviation for prostaglandins. So if we don't do anything about that, then it triggers the anterior hypothalamus, and this elevates your thermoregulatory set point. So it either will have heat conversion, so you have vasoconstriction, behavior changes, and that leads to fever, or heat production, so involuntary muscle contractions, and that raises your set temperature. So if we want to decrease a fever, we're going to give two different types of medication. One is antipyretics, which means that those are medications to decrease a fever. And those affect the prostaglandins. The same with NSAIDs or non-steroidal anti-inflammatory drugs such as ibuprofen, and that also decreases the prostaglandins. And so you don't get to this point because you've stopped the prostaglandins. An acute phase response is where an infection causes increased prostaglandin E again, production, which stimulates the warm sensitive neurons, which elevate the temperature set point. A febrile response then is elevated temperature. You have an immunological response, which is where you send out the beta lymphocyte proliferation. Endocrine response, so it increases your catecholamines. You have a physiologic response, which you have peripheral vasoconstriction and also shivering, anorexia, I mean you're not hungry, you don't feel good, and somnolence, which is just a general, I don't know what else to describe somnolence, but it's just you're tired, you're worn down, you just don't feel good. Behavioral response, curling up, because what you're doing is you're shivering here, you're changing this temperature. So when you curl up, you're decreasing your surface area so you can regulate your temperature better, or you put on warm clothes if you feel cold. There are some data processing deficits. So a couple of them is agnosis. This is defect in pattern recognition. This can be tactile, visual, or auditory. Usually just one sense is affected. And this dysfunction is in the temporo-occipital area, so towards the side and back of your head, your brain. So you look at something and you think, like maybe a visual thing, you look at something and you think, I should know what that is, but I don't know what that is. I can't recognize it anymore. Um, that would be a visual. Auditory is you hear something and you don't recognize that sound. Aphasia means impaired comprehension or production of language with impaired written or verbal communication. So for this example here, they're thinking they want to say I like cats, but they can't get the words out. They can't, it's hard to get from what's in the head out for communication. Dementia is acquired deterioration and progressive failure of the cerebral function. So causes, there's many different causes. Infection, increased pressure in the head is hydrocephalus. You know, if you have increased ICP or increased intracranial pressure. But dementia, you can have normal pressure hydrocephalus. So you don't have that buildup of fluid, but it affects the brain the same way. Chronic subdural hematoma, nutritional deficiencies, chronic drug intoxication, metabolic disorders, tumors, medical side effects, neurodegenerative disorders, and vascular disease. This is really key, this vascular disease. If you don't have good blood flow to your brain, then you are not thinking straight. Then you have degenerative dementia, and this is some types here: Alzheimer's disease, Creutzfeldt-Jakob disease, dementia with Lewy bodies, behavioral variant, frontotemporal dementia, Huntington's disease, and Parkinson's disease. All right, so now we're going to move into seizures. Seizures are a symptom, not a disease. So there's a cause to seizures. So when a person has seizures, there's a cause to it. So this is always difficult for patients to explain. So sometimes I'll have patients that, the mom will say like, "Oh, I have seizures." And I'll be like, "Well, what's causing your seizures?" "Well, I just have seizures." There's always a cause. I mean, there's different causes as you see in the list here. So it's more helpful to know the cause than just say I have seizures. But it is hard for people sometimes to explain why they're having seizures. So this is a sudden transient disruption in brain electrical activity. So usually what happens is there is something that is blocking the normal progression of electrical activity. So the neuron will just keep firing over and over and over, and it's almost like a repetitive thing. It can't go where it's supposed to go. And so then that electrical activity that's wanting to go along the neural pathway spreads outward. And again, it's like a rhythmic firing. So that's what you're going to see on an EEG is just a rhythmic firing of the neuron, but it's not going anywhere. And because of that, they have symptoms. And then, of course, it depends on what's causing it as to what the symptoms are. So some of the causes are hypoglycemia. I've seen this firsthand, unfortunately. Oh, I didn't have it, but I've seen this on patients. Fatigue, lack of sleep. Oh my gosh, it's like my whole life right here. Emotional stress, physical stress, fever, hyponatremia, constipation, use of antipsychotic drugs, alcohol abuse, hyperventilation, and hormonal changes. Some environmental causes or triggers would be like blinking lights, loud noises, certain music, certain odors, or a startle. These environmental causes don't typically cause just anyone to have a seizure. These are triggers. So if you already have a propensity to seizures, maybe there's some kind of neural pathway that's a problem or a metabolic disorder, these things can actually trigger the seizure to start. Well, this should have been before this. I apologize. So Parkinson's, this is caused by dopamine loss, usually with degeneration of the neural tissue. Primary is sporadic idiopathic. It's the most common Parkinson's, and then genetic is rare. Secondary could be neurodegenerative disease, which leads to Parkinson's. Disorders associated with the primary pathology, that's a pathway in the brain. primary amyloid pathology, and genetically mediated disorders with occasional Parkinson's features. Degenerative disorders of the spine. So these are typically related to the bone structure of the spine, the disc in the spine, the nerves coming out of the spine. So lower back pain, this is quite common. 29% of the population will complain of lower back pain. Most people, the lower back pain is self-limiting. It doesn't last for very long. Um, they take some kind of pain medication or something like that and it gets better. But there are a large population where it does not. It's a chronic pain. This area, usually between the lower rib cage and the gluteal muscles, and it radiates to the thighs. This part of your spine is, if we were a four-legged walking animal, this part of your spine is supporting your abdomen. So if you have a weak abdomen, it pulls that forward and then it causes pain in the back, in your back. Spondylolysis is a structural defect due to fractures, like fine fractures. It could be developmental or it could be degenerative. And this is usually in the vertebral arch. Spondylolisthesis is the anterior displacement of a deficient vertebrae. So spondylosis is quite painful. It's kind of a slow onset, though. It's a chronic thing. It usually affects the lower back, but can affect the neck. Doesn't typically affect the upper back. Degenerative disc disease, this is a response to normal aging, the discs that cushion between this vertebrae. As a result, you have a continuous vertical compression on the spine, which leads to chronic pain. This does have a genetic component. Only a small percentage of degenerative disc disease are incapacitated due to pain. The vast majority of us don't even know we have it until maybe you have an injury or something and they take a picture and they're like, oh, you have degenerative disc disease. And a lot of people don't even realize it's a problem. It doesn't cause a problem, but then there are some people that it causes large problems. Herniated intervertebral disc. This is also quite common. This is displacement of the disc outwardly beyond the intervertebral disc. And is caused by trauma or that degenerative disc disease. Cerebrovascular accidents, this is bleeding in the brain. So what can cause bleeding in the brain? Well, anything that can cause bleeding, period, can cause bleeding in the brain. If you're looking at and this is I believe a CAT scan. I don't think it's an MRI, but I believe it's a CAT scan. So if you look here, this line, you see this little line here and this line here, that is where the hemispheres are meeting of your brain. Should be right down the center. So that you see this one is down the center. This one is off to the side. He's kind of pushing this way. This slit right here and this slit right here should be in the middle. Those should be right in the middle. And those are two ventricles. You have four ventricles. You have the two lateral ventricles, and then you have two ventricles that sit on top of each other below the lateral ventricles. So looking at this CAT scan, you see this big white thing. So that is usually blood. So you see that here, and it is not in the ventricles because here's a ventricle, here's another ventricle. So it is not in the ventricle, so it's a bleeding into the tissue. You see this dark area around it? That is dead tissue. That is dead brain tissue. Blood in the brain is charged. It has an electrical charge. So bleeding into the brain can cause seizures because you have this abnormal electrical movement in the brain. But it also will cause brain damage. And because of that charge, it can actually, really mess up the whole brain processing. But then once the blood is reabsorbed, it doesn't have that charge anymore. So you might not see the seizures anymore. The problem is that blood will cause this damage, this permanent damage around it. So, your skull, unless you're a newborn, your skull is fixed. So your brain can only go so far. So if it's, you see here where it's this side is pushing this direction. So we also worry this is damaged, but we also worry about this edge here because it's pushing it onto the bone. So you can actually have damage over here, even though the bleeding was over here. You see a couple little dots here of white that could be blood. Um, this looks to me like an old injury, this one particular, an old injury with like the clot reabsorbing. So this is basically a vacuum or a void in the brain tissue, and there's nothing that's going to fill that but CSF. So risk factors for CVA, hypertension right up there at the top. If you don't take care of your hypertension, you're at risk for that. Smoking, of course, that increases your hypertension. It increases your chance of CVA by 50%. Diabetes, mellitus, polycythemia, because your blood is so thick, and thrombocythemia. So if you have a lot of platelets, it can cause a clot to form in your brain. And then if that happens, then the vessel can rupture from backflow of the blood. High cholesterol, congestive heart disease or peripheral vascular disease, hyperhomocysteine, cysteemia, um, atrial fibrillation because your heart is maybe throwing some clots there, physical activity, family history. Strokes tend to run in families, sleep apnea, which is huge, chlamydia infections, sickle cell, postmenopausal, high sodium, obesity, and depression. Headaches. Headaches are so not my favorite thing to deal with when the patient comes in because there's so many different causes. So you first of all have to really assess the headache, where it's at, what kind of pain is it, what triggered it to happen, what is alleviating the pain, and what other symptoms do you have? So for a migraine, you must have two. You must have two of these. Unilateral head pain, so only on one side, a throbbing pain. Pain worsens with activity, moderate to severe pain intensity, and at least one of the following: nausea, vomiting, photophobia, lights bother you, or photophobia, sounds bother you. You can be with an aura, no aura, a chronic. An aura means that there's something that you know it's coming on. So I get migraines myself, and I have the ocular migraines with the flashing lights. And so usually I see those little flashing lights kind of in the lower part of my vision. And it doesn't matter where I look, I'm always going to see them, but they're only down here. And then I know, oh, here it comes. Here comes my migraine, which is nice in a way because at least you've got to take care of it right away before it gets worse. Some will increase with your menses, they're hormonal driven. Some can have genetic triggers or environmental factors. Some people will, certain smells will trigger their migraines. So usually the clinical phases are the premonitory phase where you have vague symptoms. This is where your aura or just a mild headache starts. And it might locate, mine tends to always be like on my left side behind my eyeball. I always feel like my left eye is going to pop out. That's about where it starts. You have that aura. Not every migraine gets an aura, but that would be the next phase where it's either visual, like the flashing lights or certain colors, sensory or motor. Headache phase starts on one side and then spreads. You may have fatigue, nausea, and vomiting, and dizziness during this time. Recovery phase, you might be very irritable, have fatigue, or even depression. I used to work with a doctor who had terrible migraines, but he worked through them. Unfortunately for the rest of us, because talk about irritable, he's miserable and he makes the rest of us miserable. But a lot of times people with migraines who may not have a treatment plan or a medication that works really well, taking opioids is not really the best thing for migraines. You can actually make it worse. So there are some other medications that you can take that are designed just for migraines. Cluster headaches or trigeminal autonomic cephalgia. Typically, those are on one side, usually men, may alternate sides. The pain is usually severe, stabbing and throbbing. The problem with cluster headaches is they last for a long time. They usually last for several days, and then you'll go into remission. My brother gets these, and he's down for the count. He is in his house with all the lights out, miserable for several days. You can have a trigeminal activation, which is a release of vasoactive peptides and formation of neurogenic inflammation. Oops, sorry, I just skipped. Let me go back. Shoot. Oh, that's not what I wanted. Sorry about this. I am so sorry. I missed tension type headaches. So tension type headaches are not vascular or migrainous. They feel like a tight band around your head, and you might have hypersensitivity. It's caused by hypersensitivity of the pain fibers from the trigeminal nerve. All right, multiple sclerosis. This is a chronic inflammatory disease involving degeneration of the CNS myelin, and that causes scarring and loss of axons. It is autoimmune. It's a clinically isolated syndrome, so you have parastasis of the face, trunk, limbs, weakness, impaired gait, visual disturbances, and urinary incontinence. Optic neuritis is one eye is progressively blurring of vision and pain with eye movement. You can have the spinal cord syndrome, which is sensory and motor tracts on one side, then move to both sides. Brainstem syndrome, where you have facial sensory loss or weakness, vertigo and double vision, or cerebellar syndromes, lack of coordination, tremor, gait instability, and ataxia. Guillain-Barré is a demyelinating disorder caused by humoral or cell-mediated immune reaction. Not always sure what is causing it. Typically, it will occur after some kind of infection. Excuse me. There are different subtypes. Usually, it is associated with surgery, immunization, or viral infections, and it just kind of comes on. Most people don't even realize what's going on. You have this ascending flaccid paresis starting in the legs and moving up for quadriplegia, respiratory insufficiency, and autonomic nerve system instability. So some patients will not be able to breathe. Some aren't able to walk. They get very, very, very sick. And most of the time people will recover from it. You may not have full recovery back to where you were before it, um, and some people will actually pass away from it. Myasthenia gravis is a chronic autoimmune disease mediated by acetylcholine receptor antibodies, and you see an increased incidence with other autoimmune disorders, so people with lupus, rheumatoid arthritis, myositis, and toxicosis, they are at higher risk for developing myasthenia gravis. You have periodic remissions. It is slow progressive course or a rapid progressive course or fulminant course. So it can be slow or fast. You'll have extraocular muscles and levitator muscle affected, so the eyes are affected. So you can have diplopia, which means you see double. You can have ptosis, which means that, like in this person's picture, you see this eyelid on the left is very droopy. It's covering even the iris. That's ptosis. And ocular palsies, so that they're not able to move their eyes as well. Muscles of facial expression, mastication, which is chewing, swallowing or speech are affected. You have this facial droop. You have an expressionless face because of poor tone, difficulty with chewing and swallowing. Because of that, you'll have weight loss, drooling because you can't control the fluid in your mouth, choking and aspiration, nasal, low volume, high pitched monotone speech pattern. All right, that's all we have for this week. So I will see you next week. Have a good week.